The views and opinions expressed in the following program are those of the participants and do not necessarily reflect those of KSMQ Public Service Media Incorporated or its assigns.
Welcome to Health Connections. Osteoporosis affects 10 million Americans over age 50. Stay tuned. You're watching Health Connections. Good evening and welcome to Health Connections. I am your host, Stacie Beecham. Osteoporosis has become a major global public health concern, affecting more than 75 million people in Europe, the United States, and Japan alone. As an increasing number of our population is in the 50 and over age group, we are seeing a greater impact on our healthcare dollars. Here are some statistics concerning the state of osteoporosis in the United States. It is estimated that around 40% of U.S. white women and 13% of U.S. white men aged 50 years will experience at least one clinically apparent fragility fracture in their lifetime. It has been estimated that in the USA, 54% of postmenopausal white women are osteopenic and 30% are osteoporotic, and by the age of 80, 27% of women are osteopenic and 70% are osteoporotic. Fracture incidence in the USA is usually higher for whites and lower for other ethnic groups. The National Osteoporosis Foundation in the USA reported that by 2010, about 12 million people over the age of 50 are expected to have osteoporosis, and another 40 million are expected to have low bone mass. In 2005, in the USA, there were predicted over 2 million fractures costing over $17 billion. Now we'll turn to an earlier interview with Dr. Ann Kearns from the Endocrinology Department at Mayo Clinic. So Dr. Kearns, what is the typical age of onset for osteoporosis?
Well, typically for women, bone mass is pretty stable during adulthood. But at the time of menopause, which is when the periods stop either naturally or with surgery, there's a rapid phase of bone loss that can lead to osteoporosis depending on how good the bone mass was before menopause.
And everybody has a different bone density prior to menopause. So have we lost any bone up until that point?
Well, typically bone mass is accrued or put on most rapidly during puberty, and the peak is reached in early adulthood. And about 60 to 80% of the bone mass we get at that time is determined by our genes. And I often tell patients that it's like height, that we all are different in our height, but there is an average height for men and women. So as not to make people who are genetically below average feel that they have done something wrong. It's just what you inherited. And then as you're in your adult years, if you're healthy and have good health habits, bone loss is pretty minimal until later in adulthood for men, but typically the menopause is a big time of bone loss for women.
Because of the hormone shifts?
Yes.
Okay. And does estrogen replacement help with that? Help reduce the bone loss?
Yes. It's clear from all the studies, including the big study that said the risk-benefit may not be favorable. Even that study said one of the big favorable effects of estrogen is on bone. And we know that lower doses still have positive effects. We know that whether you take it in a pill form or a patch form, it still has positive effects on bone.
What else can we do in the 30s, 40s, 50s prior to menopause to keep our bone density at that level it was at when we were in our early 20s?
Right, so it's a good question because we get what we get and we want to hold on to it.
Right.
Maximize what you have. Well, it's clear that exercise is important. Weight-bearing exercise does affect bone mass. We know from young adults who are elite tennis players, their forearm has much higher bone density than their back arm. And that's an extreme, but it tells you that exercise is important. Enough calcium and vitamin D, and we've changed how much vitamin D we think is enough, and so it's higher than it was previous. And general healthy habits, and that includes avoiding smoking, avoiding excessive alcohol. Those are the main things.
So when you say you've changed the amount of vitamin D that you think is necessary, and we're seeing more supplements and calcium pills and such with vitamin D added on, is that a result of that?
Yes, and the amount in the supplements has generally been increased to match our change in recommendations.
And is the vitamin D need or the vitamin D deficiency different in the northern climates than in the southern climates?
Yes, that's a good question. Vitamin D is naturally made in the skin from sunshine. And we know that the sunlight in the northern part of the United States is not adequate most of the year, especially the winter months. So even if you were out there with skin exposed, you couldn't make vitamin D. As the skin ages, it's less efficient at making vitamin D, and we know that sunscreen that we recommend everyone use for prevention of skin cancer also blocks vitamin D production. So there are not that many natural sources in foods for vitamin D, so most of us rely fairly heavily on supplements or what we make in the skin.
And do we need more supplements, being that we live in a northern climate, than persons who are exposed to sun more often during the year? Or
Probably, but it's surprising that even people in sunny climates, including the Middle East, do not get much sun exposure because it's really hot.
Oh, okay.
And so they're indoors enjoying the luxury of air conditioning and are also concerned about skin damage from sunlight, so may not be out as much as we think. So although it's probably true, there are still people who don't get enough, even in sunny climates.
Interesting. I wouldn't have thought that. So we talked about the amount of bone density that you're given in your teenage years and early 20s. Is the rate of bone loss or bone metabolism rate also genetic?
Yes, there are, although on average women lose bone at the menopause. There are probably a subset who aren't quite as susceptible to that, and we don't understand. But on average, it's very similar, the rate of bone loss. But yes, there is genetic variation in that.
Okay. And menopause is the trigger for women. What is the trigger for men?
That's less clear. That's really less clear. We know that advancing age is a factor, and that's why the recommendation is at age 70 rather than 65, because we know men haven't experienced the menopause. For men, it's often other health habits that take a detrimental effect on the bones, such as smoking and alcohol.
Okay. And we've heard a little bit about bone mineral density in the media and such. Can you explain what that is?
Bone mineral density is a way that we quantify how strong the bones are. It's not a direct measurement of bone strength, but it measures bone mass, and bone mass correlates very closely with bone strength, but it's not the only factor. And the bone mineral density is obtained by an X-ray and a computer program that analyzes the bones taken on a relatively simple X-ray.
And from this, we can predict what the rate of menopause, or if a person is more susceptible or less susceptible to menopause, or to osteoporosis, excuse me.
Good question. It's important to know that a bone density measurement is a snapshot in time, and so it's like your weight. I can weigh you now, but I can't tell you whether you're gaining or losing. I can ask you,
right,
but I can't tell you. So a bone density at one point in time can't assess the rate of bone loss. But we know, depending on where you are in your life and what you're taking, what your other medical problems are, we can predict whether you should be losing rapidly or not. So it's not a measure of actual loss. It's just a measurement of where things are now.
Do you recommend for everyone to have a bone density scan, or especially women?
Especially women, and the general recommendation is all women by the time they're age 65. And that has to do with cost-effective analysis of what the fracture risk is in the near term to help us identify women appropriately. Other people who should have screening tests are people who have to take certain medications we know harm the bones.
Such as?
A big one is what we call glucocorticoid steroids.
Mm-hmm.
So that's things like prednisone or hydrocortisone, usually in pill form, that are used to treat severe inflammatory problems like rheumatoid arthritis or things related to that, or very severe asthma that can't be controlled with other things. So there are good uses of that medication. It's just a problem to know that they have bone loss. So anybody who needs those type of medications, that's a big factor. Other people are people who've already had a broken bone, who slipped on the ice and broke something, or fell in their kitchen and broke something. Those people should really be evaluated. People who have a family history of it might want to consider it. So if your parent had a hip fracture, you're at a higher risk, so you may want to consider it based on that.
And when is it most effective to start treatment for osteoporosis? Or when do you generally start treatment? When someone has already had a broken bone and comes to you, or what if I have a genetic predisposition to it, or have had a history of it in my family? I come in for a bone density scan and you find, yes, you are starting to lose some bone. Then would you start treatment right then, or would you wait till I have an incident?
Well, generally we would like to not wait till you have an incident, but we have to have some way of estimating your risk of a fracture in the next 5 to 10 years. And now we do have a new tool that's come from a lot of epidemiological research around the world. And actually the risk of fractures varies quite a bit from country to country. So it's important that we're comparing and assessing your risk based on clinical factors. So on this program, and it's computer-based and on the websites, you put in certain clinical characteristics, and it calculates the 10-year probability of a fracture. Neat. And that gives us an idea. Typically, younger people like yourself, even if they have quite low bone density, their risk in the next 10 years of a fracture is relatively low because they're young and healthy, and the risk of falling is less. So we're really moving towards not relying solely on the bone density, but on a combination of the bone density and other factors. So a woman who's 80 who has bone density that's not really low but has a lot of other factors may be at a high enough risk to initiate treatment, even if the bone density doesn't technically say she has osteoporosis. So it's moving away from just the bone density, although that's still a huge part of it.
So you would still treat or start treatment with a young person even if they don't have the risk of fracture, or wouldn't you?
Generally, we don't until the fracture risk reaches a certain threshold, and that is based on cost-effective analysis, quality of life, very technical things about what's the probability, what's the cost, what's the risk, because medications are not risk-free, and people are aware of that, and so we like to use the medications in the people who benefit the most.
Are pharmaceutical therapies still the #1 way to prevent bone loss once it has started?
They are the most powerful way to lower your risk of fracture if you're having problems with bone loss and osteoporosis, yes.
Okay.
They are used in concert with enough calcium and vitamin D because it's clear that their effectiveness can be limited or dampened by people who don't get enough of those nutrients too.
Okay. And are there new drugs in the pipeline that you feel will make a significant impact on osteoporosis therapy or treatment?
There's a lot of very exciting basic science research looking at the pathways of how bone cells are signaled to make bone, and so a lot of the more exciting and newer therapies are actually coming from targeting those signaling systems. And there is a new one that I believe is being reviewed by the FDA this summer that came from that type of research. So for those of us in the bone field who've done a lot of research and watched the explosion of information about how the bone cells are regulated, are very excited that we're using a drug that we know exactly how it works and where it came from. So that's very exciting.
Were you involved with research based? in that area?
Yeah, well, not specifically in that area. Over the 10 or 11 years I've been at the clinic, the amount of time I've spent in research has varied over time and with opportunities that came, but I wasn't involved in these specific ones that are just about to be reviewed. But I think it's very exciting for all of us to see that kind of happen.
Right. And what is the most exciting thing you have been involved with as far as research concerning osteoporosis, or could you tell us an example?
Well, I think the thing that I'm currently most excited about is using what we already know, and we already have very good drugs, and now we have a very good drug that's generic, so it's cheap. So what I'm really excited about is making sure that we have systems and ways to make sure that everyone who's already had a fracture is getting the best advice about ways to lower their risk of more fractures. And I think that's really what research and medical research is all about. It's not about proving it works in a study, but bringing it to the community and finding a system where we're making sure that all that research and all that money is going to funnel down to help the average people.
Oh, that's great. Once bone loss is at a significant measure in an individual, are there ways to rebuild the bone? We've talked about preventing more bone loss, but can we rebuild? Can we reverse osteoporosis in any way?
Well, that's a very good question, and while we really would like to do that, the currently available drugs, by and large, don't do that. There is one drug called Forteo, which does build more bone than the other standard drugs. But I wouldn't say that it can cure it, and I wouldn't say that it can ever make the bone density normal. And what I tell patients is that we're about lowering your risk of broken bones, and we can't make the bone density normal, but we know that we can lower your risk of a fracture by about 50%, and that's very good.
Oh, good.
Very good.
Good. Where are the most typical places that osteoporotic patients or persons experience fractures?
Right, so the classic osteoporotic fractures are wrist fractures for women. Men don't seem to get as much of a problem with that, but wrist, spine, and hip, although a fair number of people have upper arm fractures and foot fractures and ankle fractures. The classic are those three.
Okay, and we hear a lot about hip fractures being very detrimental to your health in many ways, partially due to limited activity, partially due to the slow healing process, and maybe the possibility of internal bleeding. Is that correct?
Well, generally, hip fractures are treated with surgery, and the average age is probably 80 to 85, so you're taking a relatively older population who have medical problems, and it is a lot of bleeding can happen at the time of surgery or at the time of fracture. That puts a lot of stress on the body. So most people survive the surgery, but most people do not quite return to their previous level of functioning. And the more illness there is before, the greater the deficits are afterwards.
So when you're treating elderly patients with osteoporosis and you're talking with them in the clinic, in a clinical setting, do you focus on preventing hip fractures, preventing falls? Do you talk about that, about ways that they can change their lives to make sure that they're using stairs less often? Is that a focus of your treatment or not?
Yes, when I talk to people about osteoporosis, I tell them that there's three things that we really need to talk about. Okay, one is getting enough calcium and vitamin D, which is essential for everyone at every age. Then I tell them that we're going to talk about prescription medications, and not necessarily in this order, but prescription medications, especially if they have osteoporosis, because those will really lower their risk of fracture. And the third thing that I talk about are what I call activity, either limitations in lifting and doing, because a lot of elderly people probably do more than they should in some settings, and it's wrapped up in our human inability to want to deal with loss of independence or, you know, admitting aging. So it's a
certainly
delicate...
a lot of people are caretakers for their spouses and need to
Yes,
lift and those sorts of things.
So it's a delicate conversation to have with someone whose gait is unsteady, to try and tell them that they may need to use a cane, but a cane signals to everyone that they're old and they're frail. And so there's a lot that goes into that, but fall prevention is a huge factor. Unfortunately, the strategies to really prevent falls are not quite as effective as we really would like. So I do spend time talking to them about those three parameters, and the way that I like to tell it is that we're talking about lowering your risk of fractures. So part of that is medications, part of that is diet and exercise, and part of that is you not taking excessive risks for falling and doing things in a way that will limit your risk of falling.
That's good to know. Which aspects of osteoporosis are costing the most healthcare dollars? What are we concerned about most in that respect?
I think that the cost of fractures and the disability that comes from them is really the biggest factor. The medications are costly, but like I said, there are now good drugs that are inexpensive because they're available in a generic form. So I think really we're talking about disability, nursing home stays, acute hospitalizations, pain medications, all of those that come from having a fracture.
So that's the number one thing that we can target as a community, reducing fractures or reducing the immobility due to the...
Yeah, and most patients, when I talk to them about osteoporosis, some of them have the perception that it's just a part of natural aging, and I would say that's probably true, but most of them I talk to about preventing disability. And that is something that everyone who's older is very interested in. Nobody says they want to go to a nursing home. Everybody wants to be independent. And so I try to help them see this program as a way to maintain independence and functionality as they get older.
Thank you so much for your time today. It's valuable information. We appreciate it. We'll finish tonight's show with tips on how you can recognize and prevent osteoporosis and strengthen your bones with exercise. Some risk factors are your sex, age, race, family history, frame size, tobacco use, lifetime exposure to estrogen, eating disorders, corticosteroid medications, thyroid hormone deficiencies, selective serotonin reuptake inhibitors, and other medications. Breast cancer, low calcium intake, and medical conditions can also be risk factors for osteoporosis. The odds of falling each year after age 65 in the United States are about 1 in 3. Fortunately, most of these falls aren't serious. Still, falls are the leading cause of injury and injury-related death among older adults. You're more likely to fall as you get older because of common age-related physical changes and medical conditions, and the medications you take to treat such conditions. A few ways to prevent falls are: make an appointment with your doctor to determine different lifestyle changes that you can make to prevent falls in your home. Keep moving. Start a regular physical exercise program. If you aren't already getting regular physical activity, If you aren't already getting regular physical activity, consider starting a general exercise program such as walking, water aerobics, Tai Chi, bicycling. Gentle exercise is good for your bone and muscle strength. Also, wear sensible shoes. Floppy slippers, high heels, and shoes with slick soles are bound to make you fall. So can walking in your stocking feet. Instead, have your feet measured each time you buy shoes, since your size can change, and buy properly fitting, sturdy shoes with non-skid soles. Another fall prevention tip is remove home hazards, such as coffee tables, magazine racks, and plant stands in high-traffic areas. Immediately clean up spilled liquids, grease, or food. Use non-skid floor wax and the like. Another tip would be to light up your living space so that you can see. where you are going. Another tip would be to light up your living space so you can see where you are walking. Use assistive devices. Your doctor might recommend using a cane or a walker to keep you steady, especially when outdoors. Other assistive devices can help too. Grab bars mounted inside or just outside the shower might help. A raised toilet seat or one with armrests might help. Also, handrails on your stairways could help prevent a fall. Now let's talk about the role exercise plays in building bone and muscle strength, thereby preventing bone loss. We should try to engage in weight-bearing impact exercises 30 minutes per day, most days of the week. You can aim for 30 minutes at one time or break it up into 3 10-minute sessions per day to improve your bone health and bone strength. If you can't fit 10 minutes in, spread your impact exercises throughout your day by taking the stairs or by parking further from the store or from work. Resistance and strengthening exercises should be done 2 to 3 days per week. Try to do one exercise for each muscle group, such as the upper back, middle back, lower back, shoulders, upper arms, forearms, hips, thighs, and calves. Do 1 to 2 sets of 8 to 10 repetitions for each exercise. If you're at high risk of having a fracture, you should work with a physical therapist to determine your exercise regimen. Low impact or non-impact exercises could include balance exercises, posture exercises, and functional exercises. Other good exercises are yoga and Pilates for strengthening bones and muscles. The information contained in the show tonight can be found on the National Osteoporosis Foundation's website at www.nof.org and on the Mayo Clinic's website at www.mayoclinic.com. Thank you for joining us and have a wonderful night.